done, and it has become such a important thing in India that people from all the corners join this program, and it is amazing. You single-handedly, and in those days, madam, I want to tell you, we had no sponsors. In the month of May, June, Corona was so rapid, so rampant. We were all very, very busy. No PPEs, no masks, no support from anywhere. And I remember you did all those efforts during Corona times and this Digio one, GAN. And I'm very happy to be a part of this. I request all the members who have joined today that I have spent 6 years as IAGE Managing Committee member. I've been a teacher for last 28 years, which already Madam has introduced me. And I've trained more than 500 endoscopists from all over India. And if you give me this opportunity to become the IAG treasurer, I will come up to your expectations, and my goal is to take endoscopy for all and endoscopy for every gynecologist. At Sion Hospital, we have treated more than 350 or 400 up till now COVID positive patients, and we have started also online courses of endoscopy with AAGL, with Spain, with RCOG. So I want you to, all of you, to do small things and then go on to do big things. But it is very important that you do not forget that your foundation is obstetrics, and obstetrics is, that's what we are here today. So please do vote. The voting lines will start from 1st of October till 15th, and I'm sure you will choose the right choice, and that's me. With this, I would like to take the opportunity now to hand over the mic to Dr. Varsha Baste, who is the most senior chairperson of Foxy. And if you can introduce Sureka madam, it would be nothing like it. Thank you.
I think Niranjan, it is the task is given to you, so yes, it is better you only do
okay.
the.
Okay. Yes, madam. So I will introduce Dr. Sureka Taide, and Dr. Sureka Taide, we all know, is a professor of professor. She is known to me for more than 12 years, apart from those personal, association which I have. Her biodata is very big, but I want people to know that she is single-handedly managing there at Savangi, Varda. She's a professor and unit head, and last 20 years she is at Sevagram. She is not only MBBS MD, but has done a DNB, FICOG, and has done FIME and FIMER fellow and PhD. It's amazing for a professor to do a PhD also. And this was all done presently. Now she's at Jawaharlal Nehru Medical College of Nagpur, alumni of GMC Nagpur, and she has received gold medal, Dr. Anand Jivne University gold medal, and recipient of Savitri by Pule Award. I can just go on and on, but she has also chaired sessions in South Africa, has also taken India to the map at USA, and she's also as an expert committee which is there available in the violence against women. She's also at the national guidelines for maternal near miss. I can go on and on, but I think I'm not going to be there in between you and her. And with this, I would like to introduce none other than Dr. Sureka Taide. Thank you, madam.
Thank you very much, Dr. Niranjan, for those very kind words. And first of all, I would like to thank my very good friend, Vaidehi Marathe, and her team for inviting me again to this very exclusive DGO Vigyan platform. This platform is unique. It is one of the first of the virtual platforms, and it has been going on so well that not only national, but we are having international participants. And of course, my chairpersons, Dr. Niranjan Chauhan and Dr. Varsha Baste, my pranam to you both, teachers, and so many friends are there. Welcome to all of you. Today, we are here for again a very important sessions, which we call as a skills and drills session. First of all, I would like to thank none other than my department, because no skill or drill session would be possible without the help of the department and without the help of, what we are today here is because of our institute. So first of all, I would like to acknowledge my institute, Jawaharlal Nehru Medical College from Wardha, and the School of Virtual Learning, which is very, very unique in whole of India. You would not find any virtual learning institute which is so active in teaching the skills, not only to the postgraduates, but also the undergraduates from first year itself. They are visiting this virtual lab, and that is all my drills which I'm going to show you today is from this virtual lab. So first of all, I acknowledge Dr. Srivastav, who is the convener and who is the director of the virtual lab, and my team who has done all the shooting, and all the drills have been conducted with them. With that, we start this session on skills and drills, and I'm not going to show any other theory, no theory, nothing about the risk factors or anything, only what skills are required in, and the training will be only on that. So what is a drill actually? A drill, the term drill and practice is defined as a method of instruction characterized by systematic repetition of concepts. We know the concepts, we know the skills, but when we are talking of drills, it means repeatedly doing same thing again and again and practicing those concepts with the help of examples and with the help of problems. So drill and practice means discipline and repetitious exercise. So whatever we are going to see today is from this virtual lab, which is our school of virtual learning. And as you can see here, we are having this very good sim, which is an advanced type of mannequin where we can show all types of presentations and positions, and the delivery can be conducted. It is a mechanized type of advanced mannequin. And here we are teaching our students, giving them problems, and they are practicing to work in a team, because obstetrics and all obstetric emergencies actually start and finish as a part of a team. If you do not have a well-trained team, you cannot have a successful outcome in any obstetric emergency. So that is called as drill. Even in private practice, we have so many support systems for us, and this support system could be our staff and even a technical staff, and they have to work as a team. And when we say a drill, it is how a team works, not what you alone are doing, but what your supporter is doing, what your person who is on the telephone is doing, person who is calling the anesthetist or blood bank is doing. So all that becomes part of the drill, and that is what we are going to see today in our first drill. Here again, you're seeing that we are not only practicing, we are doing it again and again, so that the mastery learning is there. So in a normal patients, in a routinely, you cannot allow your students to practice again and again, but on mannequins you can teach, you can train again and again, and that is what drills are. And I advise that all practitioners should go through these drills with their staff again and again, so that all obstetric emergencies can be dealt with. Now, first, what I'm going to show you is an eclampsia drill. So what you're going to see in the next slide is a video of our team practicing how to deal with an eclampsia. What I'm going to show you in the video is the technical part only. I have not shown here the attitudinal and the behavioral part, because it would have been a too big video. I'm going to show you the skill part in the eclampsia, starting from the 0 hour management. One, what you're going to do in the 0 hour. how you're going to take decision on what to do for an eclampsia, and what happens if there is a repeat convulsion, and what happens if there is an hypertensive crisis. So all this you're going to see in this video, where you're going to find a team looking after a patient in a simulated fashion. This is a simulated sort of a situation where you're going to find this primary gravida who is a 22-year-old, and she is coming to the labor room and she is convulsing here. So please look at this video and have a look. Are you able to hear?
No, there is no audio. Dr. Surekha, there is no audio.
Oh, the audio is there, but okay.
Ma'am, you can stop share and
So
reshare
full audio
with
I have
computer
here.
audio. Ma'am, you stop share and reshare with audio.
I'll
Computer
stop
audio.
share and just look at the audio.
Yeah, yeah. While sharing, you can select the audio, computer audio, ma'am.
When you share screen, there are two windows below, wherein you have to say use computer audio.
Okay.
Pregnancy patient who is convulsing, ma'am.
Yes, we can hear.
Ma'am, there's a pregnancy patient who is convulsing, ma'am. Please come, ma'am. And she's in the labor room right now.
Let us take the patient on a raincoat bed in eclampsia and first stabilize the patient. Insert a mouth gag. Do nasopharyngeal suctioning also along with it, and also administer oxygen. Meanwhile, go and ask history regarding her obstetric history and her medical history. Let us call the emergency. Let us call for help the emergency team. Take her blood pressure. Doctor has take her blood pressure and take blood pressure, respiratory rate and pulse rate.
Ma'am, her blood pressure is 180 by 110 and her pulse is 84.
Now let us perform her obstetric examination. Uterine size appears to be term size. It is a cephalic presentation. Fetal heart sound is good. Now let us administer IV magnesium sulfate. Yes, sir. For the IV dose of 4 gram of magnesium sulfate, we'll have to take 4 ampules of magnesium sulfate. This is a 2 ml ampule which contains 1 gram of magnesium sulfate. This is a 50% weight by volume solution of magnesium sulfate. So we need to take 4 ampules of this. Then we have to take distilled water which will be 12 ml to make a 20% solution. So 8 ml of magnesium sulfate, 12 ml of distilled water, which makes it to be 20 ml and constitutes 20% of solution. Okay, Smriti, now administer IV magnesium sulfate 4 gram IV over 10 minutes. Take the pulse along with it and also administer IM magnesium sulfate 5 gram IM in alternate buttocks. Ensure that the patient is catheterized. Ensure that the emergency trolley is ready containing the laryngoscope, containing IV calcium gluconate and also containing ET Also make sure that her respiratory rate is okay. Ma'am, her blood pressure is still very high. It's 180 by 110. What should we do next? Okay. As the patient is in hypertensive crisis, we should now administer IV labetalol, 20 mg IV over 15 to 20 minutes. Ma'am, I've already administered 20 mg IV labet. Even after 15 minutes, the BP is still high. It's 180 by 110. Okay, so now we should administer 40 mg of IV labetalol. And then again, we will check her BP after 15 minutes. If it will be still high, then we will again administer 40 mg, then 80 mg, and total maximum dose of 220 mg can be administered. Ma'am, the patient is throwing a second convulsion, ma'am. What should we do next? Okay, so now we should administer 2 gram of IV magnesium sulfate again. Ma'am, now the patient is stabilized and BP is also under control. Okay, so now let us perform detailed obstetric examination and a pervaginal examination. As she is having good uterine contractions and her fetal heart sounds is also good and NST is reassuring, we perform pervaginal examination. The findings on pervaginal examination are she is 2 cm dilated, 50% effaced. Station is on -2, vertex presentation. So Bishop score is good. So now let us plan for vaginal delivery, and we will give misoprostol for induction of the labor. And meanwhile, you are going to monitor her blood pressure, monitor her pulse rate, and also respiratory rate, urine output monitoring, and tendon reflexes monitoring. Yes.
So that is what we have seen here, that once your patient comes to you in the labor room, and what first of all we would like to highlight is that
we are talking of taking a history. So, and then of course we have to remember that any patient who has come to you and she is pregnant patient and she is having a convulsions, we take it that she is a case of eclampsia. So that is one thing. And what we should rule out is if she is having any fever, and if she had any other, previously she was taking any drugs, or that means a history of epilepsy. These two things if you have ruled out, then any pregnant woman coming with convulsions is considered to be an eclampsia. Then of course we start monitoring, we start the patient to take the patient to the eclampsia room, and we start the initial resuscitation. Here we have not shown that the patient should be on her side, to avoid any other aspiration or something. We take the patient on the side, we suction the patient, and we do the rapid initial assessment. Once the rapid initial assessment is done and we have confirmed that the patient has a urine output, then first thing to give to is the magnesium sulfate. In the video you have seen how the magnesium sulfate 20% solution has been made. So the solution of magnesium sulfate comes as a 50% solution, and for the IV dose we have to dilute it. You have seen in the video that we diluted 8 plus 12, that is you have to make it 20 ml. So always in the labor room you have to keep a 20 ml syringe ready. That is what the first message has been given. Pritchard's regime is 4 gram IV, 5 gram in each buttock, that is 14 gram of magnesium sulfate at 0 hours. After that, you must have noticed that the resident has been advised to check for the emergency trolley. So emergency trolley checking for the ET tube, 1. Second is the calcium gluconate. If your patient goes in respiratory depression, immediately you should be able to administer the calcium gluconate. So the laryngoscope, the ET tube, and the calcium gluconate, these are the 3 things which have to be present on each emergency trolley before you give the magnesium sulfate. So these are the 3 things which you noticed, and then we have talked about the antihypertensives to be given in hypertensive crisis. Remember 20, 40, 40, 80. That is the dose of IV labetalol, and maximum you can give 220 of milligram of labetalol. So that is the next message we wanted to give in our drill. Again, after that, we gave another message that if there is a second convulsion, you can give a 2 gram of IV magnesium sulfate again. And then lastly, we talked about the decision making. Any case of eclampsia, we have to decide about, once the patient has settled down, we have to decide the mode of termination, mode of delivery. For that, we also wanted to give a message that all eclampsias, we don't go for cesarean section. If the fetal heart is good, you have done an NST, the fetal heart is good, the Bishop score is good, then you can still go for a vaginal delivery with a proper monitoring of the fetal heart, the contractions, and your eclampsia monitoring. You must have noticed that in the eclampsia monitoring, we talked of pulse, we talked of blood pressure, and we talked of the breathing, and we talked of the deep tendon reflexes and the urine output. So this was what the message we wanted to give about eclampsia and how do we manage eclampsia. And after, of course, you have to send all the lab investigations, and depending on the lab investigations and depending on, you can, the progress of labor, you may take a decision for further. If there is any emergency, you may go for a cesarean section. But you always have to remember that we terminate the pregnancy. The mode of delivery may depend on if there are any comorbidities or malpresentations. We may go for other things, but if it is vertex presentation and good Bishop score and good fetal heart, and we may still go for an induction in a patient of eclampsia. So these are what we wanted to talk about eclampsia, and I will, if there are any question, we may take later on, but we are now going to shift to our next scenario, and that scenario is a breech presentation.
Yeah, before that, I will request every participant, please don't post your questions right now in the chat box, because there are going to be a lot of comments and we'll miss all your questions. So please post when she's about to finish. We'll take each and every query of yours. So don't worry about that, but don't post now. Also, it keeps flashing on the screen, so it disturbs the speaker as well. So just a humble request to all of you. Thank you. Sureka, go ahead, please.
Okay, so now I'm going to talk about breech presentation. I will not go into the debate whether you will allow a breech delivery or not, or whether when to do a cesarean section. All those at that debate, I'm not going to go into today's presentation, because breech in itself is a huge topic. What I'm going to tell you is all the maneuvers which we do when we go for a vaginal breech delivery. And let me remind you that even if you go for a cesarean section in a breech delivery, we have to know these maneuvers very well, because when we deliver a breech in the cesarean section, at that time too, we need all the a good knowledge about these skills. So I'm going to talk to you only about the skills, and that I'm going to show in a vaginal breech delivery. Here on the screen, you are seeing the Zatosny Andros breech scoring, which will help you to take a decision about whether you can go for a vaginal breech delivery or a cesarean section. In this, we take into consideration the parity. Here you can see if it is a higher parity, like 2 parity, then you can add 2 points. Gestational age less than 37 weeks or around 37 weeks gives you a better chance of vaginal breech. The estimated fetal weight, the previous breech delivery, what is the dilatation, what is the station, and of course, if there are comorbidities, then if it is a complicated breech, then we go for cesarean section. Otherwise, if it is a good score, then you more than 4 score, then you can go for vaginal breech delivery. That debate I'm not going to do in today's webinar. We are going to look at the skills. And the first video which I'm going to show to you is about a breech, and just watch the video. I'm going to narrate also what is happening. Okay, so just watch the video here.
Have delivered easily and spontaneously, and the decision is taken to continue with.
So this is a breech which is now climbing. This is an uncomplicated breech. She is a second gravida. You can see that you allow, this is a assisted breech delivery. You allow the spontaneous delivery of the baby till the umbilicus is delivered. So you just support the baby. Here you can see very nicely back is kept anterior, just so nicely, because it was a flexed arms. The arms were delivered on this own, and this is the Mauritius smelly bit maneuver which is being carried out by the provider very nicely. Now here the breech towel has not been used to cover, but we recommend that breech towel should be used. In the second video, you are seeing the complicated breech delivery because it is a footling presentation, but still the baby has turned on its own and delivered on its own. So no touch technique, don't touch the breech if it is delivering on its own. Allow the progress till the umbilicus has delivered. Okay, once you can see the cord, a loop of cord, you can see the provider is trying. So now this baby is trying to, turn. So what we have to do, we have to support and always keep the back anterior. So that is a very important principle of breech delivery. Otherwise, the provider should not intervene too much unless he finds that there is some problem or the fetal heart or any other problem is noticed. Here you can see the maneuver is being carried out to deliver the anterior arm. In the next maneuver, you will find that the provider is doing the love sets maneuver. So rotating the breech, posterior arm is brought anteriorly. There is two loop of cord around the neck. Still, the provider is not in panic. He has loosened the two loops and allowing the baby to hang by its own weight. Here you can see very well. And then again, the Mauritius smelly whip maneuver is being carried out. I will talk about it in detail in my next video and see very nicely the baby has been delivered and we are having a crying baby. So these are the two breech videos I have shown to you. One was an uncomplicated, a frank breech, and another was a footling presentation. But still, the baby, the principles we have to remember about breech delivery is this is an assisted breech delivery. In the assisted breech delivery, we do not touch the baby till the delivery of the umbilicus has been achieved. Now, we should also remember that there is something called as a spontaneous breech delivery and something called as the breech extraction. Spontaneous breech deliveries, you're not doing any maneuvers and the baby is coming on its own unless it is a preterm and a multiparous. So we do not allow a spontaneous, we always assist the breech. But in the second baby of the twin, we can do the breech extraction, wherein we start the maneuvers starting from the delivery of the hip and the breech. Now, what I'm going to show in the next video is if there are some complications. So where can these complications occur? This can occur at three levels. The first level is the hip, the second level is the shoulder, and the third level is the aftercoming head. I am going to show you maneuvers at each and every step. But remember that in breech delivery, we do not do maneuvers unless we find that the breech is stuck up somewhere, and that's why it is not delivering on its own. So in assisted breech delivery, we start the maneuvers from the shoulder and for the aftercoming head. Now here we can see what is seen in this video is I don't know why it happens. Has the video turned for you also?
Yes, a bit.
I don't know why.
Yes, but never mind. We can
okay.
Anyway, correlate. Your hand is at the foot end side, right, of the table. If you can just with your cursor show.
You can see. Okay, so here you can see that the maneuver is done to, this is called as the single groin traction, where you insert the index finger and you give traction in such a way that you deliver one leg. In the next, I am going to show you the Pinard's maneuver. In the Pinard's maneuver, what happens? The knee is extended. So you give traction on the popliteal fossa and you abduct and then you deliver. Okay, so this is how the legs are delivered. So either you use a single groin traction or you can use the Pinard's maneuver. And remember that you have to always keep the back anterior. If the baby is trying to move laterally, then you can just assist to keep the back anterior. loop of cord should be little bit pulled down and kept on the side. Allow the baby to deliver till you are seeing the shoulder. Cover the breech baby with a breech towel, and then of course you have to look for the scapula. Here you can see that both the scapula are parallel to the spine. If there is winging of the scapula, you can deduce that either it is an extended arm or a nuchal arm. Nuchal arm means the baby is around the neck of the baby. So in that case you may require the Lovset's maneuver. Now what is the Lovset's maneuver? In this maneuver we see that the posterior arm is always at the lower level as compared to the anterior arm. So you catch the baby in a femoropelvic grip. The thumb is parallel to the spine and the forefingers are curled around the hip of the baby, and then you turn the baby in a 180 degree, keeping the back anterior, and you rotate the posterior arm. So now you will see that the posterior arm is rotated and made anterior, and as soon as you rotate, the arm is seen below the symphysis pubis and delivers on its own. You can hook the arm and then deliver the baby on its own. So this is the Lovset's maneuver. Now what is the Lovset's maneuver? In this maneuver,
Dr. Surekha, I think we've lost her. Her network is lost because we are not able to see her also in the video.
Yeah, ma'am, she'll rejoin in a minute.
Call her.
Yeah, I'm calling.
Meanwhile, I would like to share with all the participants that today's CME has been granted 1 ICOG credit point, and I put in the message into the chat box. There are 2 numbers from where you can know how to avail this credit point. So kindly note these numbers. You have to call up these numbers and they'll let you know how we can go ahead with the procedure. We have just lost connection with Surekha ma'am. She's trying to reconnect with us.
Meanwhile, I would like to ask Dr. Niranjan, do you have such mannequin at your setup?
No, madam, we don't have any mannequin, but there is one company which is there. It is a German company, Lardel, and we had done a workshop in 2018 when Dr. Rishma Pai was the president, and they have a live mannequin where they can teach the pre-eclampsia drill, eclampsia drill, where the blood pressure fluctuates. Also how to go about and deliver a patient. Different maneuvers are there. So they had again contacted me again. So I'm sure this labor drill which Dr. Surekha Taide has been doing is amazing. And
I think it is more practical.
Yes.
The repetition of the same skill. So it really is very useful for the young gynecologists, the obstetricians, to learn practically.
Because I remember, madam, when I was a house surgeon in 91, 92, I'm sorry, but we have learned by our mistakes.
I know.
I'm sure everyone has done so. When even episiotomy, the extension of episiotomy used to occur. Sometime when we used to lock forcibly the blade used to go inside and cut the vagina. A lot of things are happening, and now see, in those days, medico-legal problems were not there, and now
I know.
madam, it's very important that even in government municipal hospitals, we have RTIs, and we have all to be very careful while communicating all
I know.
and That is very important. So now I
Very
think
nice.
this training drill and the training of delivering a breech, training of delivering a normal labor, application of forceps, and record of the fetal heart
Are
sound.
you able to see me?
Yes.
Yes,
Yeah.
yes, madam.
Yes, carry on.
Please,
Yes, Dr. Sureka, go ahead.
please. It's a wonderful.
Okay. Okay. So, where did I disconnect?
Yeah.
Okay. So I think I should start with the breech
At
video
the
again.
scapula level.
Okay. So I have to go.
Full screen.
Yes. Okay.
Yeah.
Yes.
Yeah. Right. So we were there at the
Position of the
delivery of
vagina. You
the
cannot see
love sets
the
manure. I think
inherent
the love
delivery
sets
of
I am going to show
an
again.
extended, or
So
there may be a nuchal arm. You can allow the arms to
now we have delivered the baby up to the umbilicus, and we have now pulled out the cord. And the next thing, of course, you keep the back anterior always, and you look at the scapula. You cover the baby with the breech towel here, and you look at the scapula. If the scapula is parallel to the spine, then it is fine. If the winging of the scapula is there, then we have to decide that the arm may be either extended or it may be a nuchal arm. So in that case, what we do, we go for either the Lupset's manner, or you could go for delivery of the posterior arm, that is another maneuver. Here I'm going to show you the Lupset's maneuver, in which you can see that the posterior arm, you can notice that the posterior arm is always at a lower level as compared to the anterior arm. So if you rotate the baby, then see what will happen. You catch the baby with the help of a femoropelvic rib. What is a femoropelvic rib? Your both the thumbs are parallel to the spine, and your the fingers are curling around the hip. Now with this femoropelvic rib, you turn the baby in 180 degree, and you make the posterior arm anterior, keeping the back anterior. Baby's back should always be anterior. Now you can see, as soon as you turn, the arm is visible below the symphysis pubis. You can hook it and you can deliver. The other arm may deliver on its own with this maneuver, or you can again perform the Lupset's maneuver, and then you turn again the baby in 180 degree, keeping the back anterior. Again, the posterior arm is made anterior by rotating in 180 degree in this way, and you can see now again the arm is visible, which you can hook and you can deliver. Okay, so now both the arms have been delivered very well. Now for the aftercoming head, there are three maneuvers which we can do. First maneuver is called as the Burns-Marshall technique. Second is the Mauritius smelly wit maneuver, and third is the Piper's forceps. I will show all the three maneuvers one by one. Now for the Burns-Marshall technique, you allow the baby to hang on its own weight, and then you allow that to happen till the nape of the neck is visible. Now you catch the legs of the baby. You can see that the legs of the baby are caught hold of in a very typical grip, in which the index finger is between the two legs, the thumb is on one side, and the other fingers are on other side. In this way, you grip the legs of the baby. Then your assistant may give a suprapubic pressure to maintain flexion, and your other arm protects the perineum of the baby. And you carry the baby in a complete arc over the mother's abdomen. And now you can see very nicely. So be gentle, and you deliver the baby by carrying the baby over the mother's abdomen. And then you could clamp the cord, and you could go for the, again, you can hand over the baby to the neonatologist. So that is how you do the Burns-Marshall technique. Now I'm going to show you the Mauritius smelly wit maneuver. This is a maneuver which is, more controlled. If you are not having good amount of flexion and you want to control the delivery yourself, I prefer to do an MSV as compared to the Burns-Marshall technique. But lesser skilled people may prefer the Burns-Marshall technique. If the baby's weight is more, then also we could prefer the partial, the MSV, which I'm going to show you here. Now the MSV, again, you allow the baby to hang by its own weight here, and then you catch hold of the baby's legs and you insert your left arm below inside the vagina, and then you keep your index finger on one malaprominence, the ring finger on another malaprominence, and the middle finger in the mouth of the baby. Then right hand, see, finger on one shoulder, the ring finger on another shoulder, and the middle finger in the suboccipital region, and you give a traction towards yourself and you carry the baby up first towards yourself and then upwards. Okay, so here you can see, now I'm going to show to you how the fingers were inside. So index finger on one malar prominence, ring finger on another malar prominence, and the middle finger was inside the mouth of the baby to increase the flexion. In the modified MSV, we may put the middle finger either on the chin of the baby or on the root of the nose, and you could assist the flexion, and by assisting the flexion, the smaller diameter presents, and that is how the delivery can be assisted. So this is how you assist the flexion and you could achieve the delivery by the MSV. Okay, now we are going to show you the Piper's forceps. Piper's forceps, I don't think many of us has seen during even our residency, because Piper's forceps actually is not available in many institutes. This is a longer forceps as compared to the Wrigley's forceps. But let me tell you that even your Wrigley's forceps can be very well used to achieve a delivery of the aftercoming head by the forceps, and I'll show you how it can be done. See here, allow the baby again to hang by its own weight. Let the nape of neck be visible. Then ask your assistant to hold the body of the baby away from where you are performing your procedure. So this is how you hold the baby away. Do the phantom application of the Wrigley's forceps. This is the Wrigley's forceps I am using, the outlet forceps. Identify the left blade. Then again, take the 3 fingers of your right hand, insert the left blade inside the vagina. You can see, I'm going to show you. You apply the some lubricant and now insert your forceps blade by the side of the head. This is a mento-vertical application. Insert the blade adequately inside so that the shank rests on the perineum. Okay, don't keep it outside, otherwise it is not going to lock. Keep the blade adequately inside. The shank should rest on the perineum. The other forceps is, other blade is inserted over the first. Then assure that there is a good locking. You can see very nice and simple locking has been nicely achieved. Both the blades are adequately inside. You now grip the forceps with your index finger in between the two, and now first towards yourself and then upwards. That is how so easily and in a very controlled manner you can deliver with forceps. So you have seen here that Piper's forceps may not be actually necessary, and you could use your outlet forceps to deliver this baby. Sometimes, what happens. So I'm going to show you in this video how the Lovesets maneuver, what is the principle. There may be some postgraduates also listening to this webinar. For them, I have put this video. What is the Lovesets maneuver and what is the principle behind it? Here you can see I'm showing the pelvis and the posterior wall here. You can see it is quite long and 12 centimeters. The anterior wall made by the symphysis pubis is only 4 centimeters. It is deficient here. Okay, here it is deficient, and if you can see in the normal anatomical position, the posterior arm is always at the lower level as compared to the anterior arm, and that's why what happens when you try to deliver the baby in the posterior arm will always be at the lower level, and if you turn the baby in 180 degree and with a Lovesets maneuver, I have already shown you that maneuver. And what will happen that when you make the posterior arm anterior, the arm will just come out on its own, because that the anterior part is deficient. That's why you find that when you turn, always the arm will deliver on its own. That is what I wanted to show you. Again, I have performed the Lovset's maneuver again, and you can see the maneuver has been very nicely performed and the baby's arms are delivered. So this was the about the breech delivery. But sometimes what happens, you know, if you may get stuck with the delivery of the aftercoming head. And I can assure you that this video which I'm going to show you is an exclusive video. You may not find this video anywhere. This video has been procured by me when I was a trainer for EMOC, that is the Emergency Obstetric Care Project, and we used to teach our medical officers how to go and do a breech delivery. If you do not have any cesarean section facility and your patient is presenting to you in a fully dilated way, then how to go and do it. Now, symphysiotomy, let me tell you, you may need to learn the symphysiotomy technique, and you may encounter this situation once in your lifetime. In fact, you know, if you are doing a 30 years of practice, then maybe once in a lifetime you may get stuck in a breech delivery or a shoulder dystocia. Also, the shoulders are not delivering, and that is when you may do a symphysiotomy. Symphysiotomy used to be done for a long, you know, number of times in the early 19th century, but after that it has been stopped with good cesarean section facilities and all available. But once in a while you may need to do it, and that's why I'm going to show you this technique, where you are now seeing that this baby has stuck, the aftercoming head is not delivering. It may be because of various causes. One of the cause is that it may be a little bit, you know, android type of pelvis and the baby's head is stuck. In that case, you may get in a panicky situation, and that is where a symphysiotomy may come handy, and that's why I'm going to show you this video. Okay. Now what
For symphysiotomy,
you can see
infiltrate the
is
skin
that in this video, what I'm showing you is the lignocaine, the local anesthetist is being injected in this area. This is the symphysis pubis area. You should always have a red rubber catheter or a plastic catheter in this way, which once you insert the catheter, you know, yes, you are in the urethra. Then with the help of your index finger, you take the catheter away from the midline so that the urethra is away from the midline. Then with the help of a fresh new blade of the scalpel, you have to cut through only the anterior ligament of the symphysis pubis. Don't go up to the posterior ligament. You just want to give a little bit of nick only on the anterior ligament of the symphysis pubis. Then allow the baby to, you know, separate whatever little bit of separation is required of the symphysis pubis will be taken place spontaneously when you deliver the baby's head. So don't cut through whole of the symphysis pubis. What you require is a red rubber catheter or a plastic catheter. You may require this anesthetic and a sharp blade, and of course what you require is courage when you do a symphysiotomy. Okay, once the symphysiotomy has been done, then you, for the healing, you do not require to suture it. You can strap the knees of the patient to each other and allow a little bit of rest for 24 to 48 hours, and then healing occurs. You don't need to actually suture the symphysis pubis. So this video I have shown to you because once in a lifetime you may encounter, and that's why I have shown to you this symphysiotomy video. Now, of course, we know that breech delivery has its own complications. So that's why we most of the time would like to try and convert the breech presentation into a vertex presentation. And that is where the external cephalic version comes into play. And if you remember, in the antenatal management of a breech, we always say that you should go for external cephalic version. But how many of our obstetricians nowadays know external cephalic version? Because this skill has not been handed over the years to our junior staff or our junior faculty and to our postgraduates. That's why the external cephalic version is not being used that much. But remember that it is a very this technique, if you learn the skill, you can very easily achieve the conversion of a breech into a cephalic. And it is advisable, and the protocols and guidelines always say that antenatal management of breech is nothing but ECV or external cephalic version. So again, it's a big topic, when to do, why to, but I'm going to, in short, tell you what is an external cephalic version and what is the, how you are going to do it. So I'm going to talk about only the procedure of external cephalic version. You can see the video here, and of course, when you do the external cephalic version, the fetal risks actually are negligible in an external cephalic version. Only thing which can be possible is if you have done the external cephalic version, sometimes you may meet with a fetal distress and you may have to take the patient for cesarean section urgently. So we advise that you should do an external cephalic version nearing term. When the patient is nearing term, that is around 37 weeks of gestation, you should do the external cephalic version. Why? Because if you meet with some complication, like if there is the bleeding starts, or if there is a fetal distress and you may have to take an emergency cesarean section, then you are sure that at least your baby has completed the 37 weeks of gestation. The baby is a term gestation, and all the spontaneous versions which occur in the breech, you know that the breech is so common in the preterm, around 24 to 28 weeks, 25% of the babies may be breech, but nearing term, because of spontaneous version, most of them are not breech, they convert into. So all the spontaneous versions has occurred, so you do the external cephalic version nearing the term gestation. There are certain contraindications which you should know about, like ECV, and that one of them is any, not only a previous cesarean scar, but any scar on the uterus. It may be a myomectomy scar also. You don't go for ECV. And any complicated, other factors, even IUGR or an oligohydramnios, fetal anomalies, uterine anomalies, you don't go for an ECV. So basically, you're talking of a uncomplicated patient. The only complication is that she is a brief presentation. So in that case, you can go for a ECV, and I'm going to show you the video of the procedure. So let me have a sip of water. Till that, you can watch the video.
Part of this checking for the contraindications involves doing an ultrasound.
So what you're seeing here is, before doing the procedure, the consent is important, and an ultrasound is important to find out where the placenta is, where the back is there a flex head or not. Cord around neck or short neck, you don't. Then what you can see here is you do an NST. Here you can see that some tocolytic has been given, and now you have seen that the back is on this side. Okay, so where the provider is sitting, back of the baby is on that side. So in ECV, there are two somersaults which we do. One is the backward somersault and another is called as the forward somersault. I'm going to show this first video a backward somersault. For the backward somersault, what we do is we actually sit very nicely, take a stool, take a low stool and sit there by the side of the bed, and you sit on that side which is on the back. Wherever the back is, the provider should be on that side. You can nicely put talcum powder on the abdomen of the mother, or you can use your gel of your sonography. Okay, so that your hand nicely slips on the abdomen of the mother. Then you take your 4 fingers of each hand, so you have 8 fingers, and you first of all dislodge the breech from the pelvic. Okay, so you dislodge it very gently, so that you do not incite any contraction, Braxton contractions you do not incite. Then you dislodge that breech away from the pelvic area. Once it comes in your hand, then you take that breech in one hand. Now you can see that it is caught, the breech is now caught. You again sit down nicely and do very gentle manipulation only of the breech. In the backward somersault, all the pressure is applied only on the breech, and try to rotate gently, allow the baby, to turn on its own. Do not exert too much force on the breech. Sometimes what happens, there may be a short cord, or the cord is entangled around the leg of the baby, and that's why the baby doesn't turn. The baby is not turning, that means there is a problem. Most of the time you find that the baby, turns very nicely, and you can see now the provider is talking to the patient, asking if there is any pain, anything, and very gently the manipulation is being done, so that the breech is turned on that and very nicely. In between, you should always look for the fetal heart. If NST also can apply it if your backward somersault is not successful and you want to try the forward somersault now, then you have to do NST in between or check your fetal heart, assure that everything is fine. Now you have seen, again I will go back and show you. Now this provider is doing a forward somersault. So now the provider will go on the other side of the patient. So on the side where the limbs are. For the backward somersault, you are on the side of the back. For the forward somersault, you are on the side of the abdomen or the chest. Okay? And then for that, you again dislodge the breech with the help of your 4 fingers of each hand. That is 8 fingers. You dislodge, you take the breech in one hand, and now you are manipulating the head of the baby. You are seeing that the more pressure is applied on the head, you little bit shrink the size of the baby whole fetal ovoid, so that you increase the flexion, and then you give more traction on the scene. Very nicely the baby is now turning, okay, and the mother will feel the difference, so you are nicely seeing the pressure little bit applied. The head is now going down very nicely. The ECP has been done. Baby moves on its own. Yes, now the baby has turned, and you will see that the cephalic pole has come lower down. Once you achieve this, then you again do an ultrasound, bedside ultrasound. You can see, yes, this is the breech, and yes, this is the head, which is very nicely come up here. You can do an ultrasound and assure that everything is fine, and you will also have to, you may ask the patient will say yes. Do record the fetal heart and assure that there is the fetus is good, and you have done the ultrasound and you are finding that now the cephalic pole has come down. This is another patient. I will not go into it because it is the same thing again and again. Okay, but these 2 videos we have recorded when I was doing this, when I was doing the EMOC training, and this is the course we have done for a trainer's course. Okay, so again, so I just want to make one point here before I go to the other scenario, that ECV is quite simple, and you have to not only practice yourself, it can be done in the OPD, it can be done in the ward. So you have to know the skill and practice the skill. Always take a consent, though it may be an OPD procedure. You always take the consent, do it only around 37 weeks, that is a term gestation. And you should always think of if there is any contraindication. So don't do it in any previous cesarean section. Even oligohydramnios, the baby doesn't turn. In polyhydramnios, the baby turns, but the patient goes home and again it becomes breech. So certain contraindications are there which you should not do. If there is an antepartum hemorrhage, she is having a placenta previa, or she is an abruption, please don't do an ECV. Otherwise, ECV is a simple procedure and it's done in the OPD only. Okay, so we need to think over it that, you know, breech presentations, their delivery may have its own complication. Even a cesarean section is, you know, difficult. So let us do the ECV and promote the ECV and train ourselves and our students to do this ECV. So that is why I put in this drill or the video, and of course you will need some practice, you will need some training, and then only you can achieve and acquire this skill. So that is very, very important. Yes, breech, all the breech needs practice. Do the practice with the help of your staff, your even a small mannequin is available. The pelvis, you know, articulated pelvis, you can, the doll is there, you could practice and you could acquire this skill. These skills are very important, because if we don't acquire them now, then we cannot give them to your next generation, and it may happen that we will forget the skill of vagina breech delivery. I know that Vaidehi has not added the shoulder dystocia in, but I had some videos and I wanted, so this is all, so that's why I'm showing shoulder dystocia. Before I go for obstetric hysterectomy, I will just show few drills of shoulder dystocia, because again it is my topic of interest. And
no problem, it will more the merrier, Dr. Sirekha.
Okay, so for the shoulder dystocia, again I don't go into the theory. We know the risk factors, and we know that we have to be alert all the time when we are doing a vaginal any delivery for that matter. We know that there are certain risk factors like a previous shoulder dystocia, or a GDM patient, or macrosomic baby, or obesity, and these may be some risk factors. Instrumental delivery also a patient may land up into shoulder dystocia. But let us remember that shoulder dystocia comes out of the blue and it can happen to any patient. So drills are again important here. You may not encounter in your whole lifetime, but once in a while you may go into a fix, and that's why we need to learn these maneuvers. And remember the acronym HELPER. H is called for help, E is evaluate, episiotomy you have to give, L is legs, because you flex and abduct the legs, that's why L in the macrobird's maneuver. Then P is giving a suprapubic pressure, E is doing all the rotational maneuvers which I will show you one by one, and R is removing the posterior arm, and R is again roll over the patient on and do the Gaskins maneuver. So remember helper, and we will see in this a very short video, all the maneuvers are shown one by one. Okay, I'm going to just run through, it's a very short video. Here you can see the macrobird's maneuver, flexion, abduction, the shoulder gets released.
In front of the
Then
posterior shoulder,
here you can see the rotational maneuver. Anterior shoulder is made posterior, and with that rotation itself, in the second, the posterior shoulder gets rotated and turned anterior. Again, it is needing that way a practice. And remember that the hand has to be brought over the chest of the baby. Don't do it other ways. Okay, always bring it over the chest. It is Gaskins maneuver on all fours, and you just have to take the baby downwards and upwards. Now this video showed one by one what you can do, and in the next video I will show you little bit slowly, deliberately, so that our students, if they are watching this webinar, they would know, practitioners will know what exactly is being done. Okay, so one by one I will show all the. Now here you can see the turtle sign in this drill which we are performing. So this is again a drill. When we say drill, we deliberately do the things on as a practice session. Okay, so you can see the head is jam packed here, head has delivered. Now it is getting retracted against the pubis, against the perineum. Okay, what we did, 1 minute, I will show it again. So head is now impacted here, and what we are seeing that the head is getting suffused. It is getting all red, and shoulders doesn't, you give traction, shoulder doesn't deliver, and that is called as shoulder dystocia. It's called as the turtle sign. Everybody should be able to recognize the turtle sign. Once you see the turtle sign, do not give too much pressure. The head will get, the shoulder will get more impacted. You have to do, first thing you do, call for help. Second thing is do the macrobirds maneuver. In macrobirds, you can see your assistant, both the assistant will suddenly flex and abduct the legs. Okay, and give suprapubic pressure. Now I'm going to show you the macrobirds again. So the head is got impacted. You can see the turtle sign. You suddenly do the flexion and abduction, and then you are going to give the suprapubic pressure, and the shoulder gets released here, and you can now deliver the shoulder. So this is a very simple maneuver, and you have to train your assistants to do this. Okay, so this is a simple macrobirds maneuver. Then if you are done the macrobirds, and now again still the shoulder is not coming out, you could do the other maneuvers. This is the corkscrew maneuver I am going to show you in this video. For the corkscrew maneuver, what we are doing is, you go inside and you rotate, you go inside from the anterior side, and you go and hook the shoulder, the axilla, and carry the baby over the chest. Okay, you always carry it on the side of the chest, not the other side. So that is when you go for the anterior arm and you try to remove it over the chest of the baby. So this is one rotational maneuver which you can do. Other is when you go for the posterior arm. Now in the posterior arm also, this is the Wood's corkscrew maneuver. You go inside. Okay, see, she tried to go on the other side, but then she remembered the chest is on this side, so she went inside from the other side, and then she has to rotate in such a way that you turn the baby, and then you have seen these are the corkscrew maneuver. This is not the delivery of the posterior arm. You remember in the helper acronym, it is episiotomy, then macrobirds, then rotational, and then delivery of the posterior. This was the Wood's corkscrew maneuver. I will show it again in the next video. I am having a very good video of this shoulder dystocia, which I will show.
Dr. Surekha, can you mute the audio of this video?
Okay.
Yes. Because then we can't hear your voice well. Yeah.
Now you can hear me?
Yeah.
Okay. Now I'm going to show the rotational maneuvers again. Okay. So that we know, see, you have to remember, either you make the anterior arm posterior, or you shift the posterior arm and make it anterior. So you rotate. Once you rotate, what happens? The space is created, and then you can hook. Okay. So that is what is shoulder dystocias, rotational maneuvers. So you can see very well in this. Okay. So you're shifting and you're rotating. Okay. Once you rotate, then you get space and you can deliver. Okay. So that, and always, now this is an actual case of shoulder dystocia where they are trying to deliver the posterior arm. Actually a difficult one. You can see the baby is very hefty. So what they did, went posteriorly and removed the arm like this. They don't have the mannequin. They are using only the fingers like this. Okay, and that is how this is called as this. They don't have the mannequin, but they're still practicing. So this is called as drills. You do, now see the macrobursts, flexion and abduction. Okay, so what that does, it releases the arm here below the symphysis pubis, and you can see the arm is being released. Again, I will show you that part. See here, the arm is released just because of flexion and abduction. So that is the macrobursts. Okay, I will just go little forward in this video. I want to show you an actual sorry, this is another video I have come to. I just want to take little bit forward. Okay, I started from here. So this is delivery of the posterior arm. Now see the actual, they are using a string here which they hooked in the posterior arm, and then they brought that arm forward. Now here is an actual shoulder dystocia tortal sign. The hefty lady, you can see flexion, abduction. They are trying to deliver this. The suprapubic pressure has been given, not coming out, trying to deliver the posterior. So this is called as delivery of the posterior arm. Go inside and hook the posterior arm and remove it. Again, still they had problem, very hefty, and they could remove the baby. So this is an actual case of shoulder dystocia. The baby is crying, healthy baby. And see, hefty little bit. So macrosomic babies are known to cause shoulder dystocia, but it doesn't mean that only macrosomic babies. Okay, so you have to remember that even your simple instrumental delivery, if you have done even a 2.8 kg baby also, you can have a shoulder dystocia. This is the turtle sign here seen, and you are seeing that in this small feeding tube is being fed in the posterior arm. Okay, the axilla, they are putting a feeding tube. You can see that feeding tube, and then with the help of the artery, they are rotating the posterior arm, making it anterior. So that is the principle actually, rotate and make. And once it comes anterior, then you get space. So it's a panic position. You can see very nicely the arm has come out. Okay, the baby is hefty. Again rotate and remove the baby. So this is an actual case of shoulder dystocia which I wanted to show you, and that is why I put in. So I will take your questions later on if somebody is having why and how this happened. But these are the rotational maneuvers which you need to practice. So let us remember again: macrobursts maneuver, rotational maneuvers, anterior arm can be made posterior, or posterior arm can be turned anterior. You get space, hook out, and remember. If there is no space to turn, then directly go posteriorly and remove the posterior. That's called as delivery of the posterior arm. And always remember, when you are delivering the posterior arm, it has to be brought over the chest side, chest and the face, okay, and not the other side. Don't try to bring it from the back, it will never come. Okay, so rotate it like this on the face and the chest of the baby and deliver the posterior arm. You have to practice this, otherwise once in a while you will face it and then you will have nobody to help you. So always practice the shoulder dystocia on your maneuvers. Now the last part of our webinar, and that is obstetric hysterectomy. Okay, just watch this video. What you will do in this kind of situation. This is an atomic pipette. You can see very well how much she is bleeding. Okay, we are trying to remove, and it is a huge torrential bleeding.
please.
So these are the situations where actually you need to take decisions. Okay, so you can see this situation. This patient has landed up with chronic BPH, and once the whole blood is suctioned out, you will say that this patient was of a abruption, ovular uterus was there, and because of that the patient landed into torrential hemorrhage, and these are the situations we need to take decisions. So any such kind of cases, what is important is what the team is deciding. Okay, now apart from the blood, the anesthetist, or the support, the person who is in charge has to take decision what she or he will do, whether you go directly for peripartum hysterectomy, or do you have some time for internal iliac ligation or something like that. In these kind of panicky situations, to save the life, many times we need to take the decision for obstetric hysterectomy, because there is no time actually to do an internal iliac, or you may not even have the skills to go ahead with an internal iliac. And to save the life, this is how these are the situations which you may have to do a obstetric hysterectomy. Now look at the second case. Here you can see that all of the anatomy is distorted, and you're not able to see what is there, where is the peritoneum, where from to open, where is the uterus. Nothing is being actually delineated well, and what you are seeing is either is it a uterus or is the baby's parts. So now the surgeon is trying to find if there is a leg, the baby's leg can be brought out. And yes,
Dr. Sureka, can you mute the audio of the video you're showing?
Yeah. I'll show it again little bit. Okay, so they have opened up. What they are finding, they are not able to actually see anything, so they go inside and pull down the leg of the baby. Okay, and you can find that once they bring down the leg, so this is the leg actually. So leg was brought down. So always, it's very good to bring down the leg instead of anything else. And once you have one leg, you are able to go to the other leg. So you can see it is a rupture uterus. This is the leg, and the baby has been delivered. And after that, you can actually check what happened, how is the rent, whether it is repairable. If it is a lot of hemorrhage is there, and it is irreparable, then again these are the cases you need to go for obstetric hysterectomy, and these are the cases where decisions have to be taken. So let me show you one by one. So again, I always show this Taj Mahal. Why? Because not for its beauty, but to show people, yes, it's not about beauty, but this is about how we have it is not showing beauty, but it's showing what the women has suffered. 14 times she was pregnant, and she died in the childbirth. So this is Taj Mahal depicting that how women have died in childbirth. Again, you can see here Smita Patil, she also died during childbirth. So many women are dying because of just because of obstetric hemorrhage and the skill which was not there to do a hysterectomy. So is obstetric hysterectomy obsolete, or whether this skill has to be given to our junior staff and our postgraduates and our faculty? So it is not obsolete. There are certain situations where we may have to do, and these are again the various types of peripartum hysterectomy or obstetric hysterectomy which you can do. It can be performed in an emergency, but if it is a placenta accreta, then you can plan the obstetric hysterectomy and do the obstetric hysterectomy. In case of a placenta accreta, it can be done in a planned manner. It can be a total or a supracervical. It could be you could remove the ovary or you can preserve the ovary, because most of the time they are young women. We preserve the ovary when we do a obstetric hysterectomy. So again, I'll show you one by one. This is one case of atonic hemorrhage. If this kind of hemorrhage is there, a torrential bleed, then of course you will not wait. If this kind of picture you see, then you will not wait. Here you can see again the radiological imaging. The elective OH was performed. I think it's going very fast. I'll show just one by one. This was a case of again placenta accreta, where obstetric hemorrhage was there, and because of the adherent placenta, here you can see there was some attempt to remove the placenta, which should not happen actually in a placenta accreta, that you trying to remove that placenta. This was an undiagnosed case of placenta accreta, and that's why the resident tried to remove the placenta, and then there was torrential bleeding, and the patient had to be taken for this. But in this case, it was already diagnosed, and we did the obstetric hysterectomy in a planned manner here, because we saw this kind of radiological picture. Elective which was performed. This is a, now again you can see, I'll go back a little bit. This is a case of scar rupture, maybe in the peritoneal cavity, and again you see that because of a huge rent, again obstetric hysterectomy was performed here. This is a rupture which was vertical. See the rupture uterus following use of prostaglandins. The patient came to us with shock, in shock index of 1.7. 3, and so much blood and FFPs were given, and obstetric hysterectomy was done, and the patient survived here also. Again, this was a rare case of this obstetric hysterectomy here has been done. Here this was a case. 1 minute, I will just go back again. So this was a case of, you know, in the horn of pregnancy. This is an ectopic pregnancy. So obstetric hysterectomy had to be done for torrential hemorrhage. In this case, you can see a perforating mole. This one is a perforating mole. So these are the indications I just wanted to tell you, because performing an obstetric hysterectomy is not a very big thing, but taking a decision is a important thing, and that's why I'm showing you all these videos. What are the, actually this is an abruption with this, where we can do. Actually the video is running very fast. So this is a placental abruption. You can see the amount of bleeding, and that is where we did a. So these are all the indications of obstetric hysterectomy. You have to take a decision. That's important. Procedure, again a vertical incision, round ligament has to be clamped and cut, and go for the infundibulopelvic pelvic ligament. Look where the cervix is, apply the clamps, and remove the uterus. Very quickly you can do it, and to show it here, you can see here this patient where the hysterectomy was done. So the placental vessels are being seen. Probably it is an accreta. So we give a vertical incision to a classical cesarean section. By a classical cesarean section, remove the baby without touching the placenta. Just remove the baby. Upper segment incision, vertical given. Baby has been removed. Okay. Now exteriorize round ligament, anterior peritoneum. You can see the vessels. This is the other side of. So sometimes it is very simple to dissect the anterior peritoneum. In atonic PPH it is easy. There is no. My battery is running low. Iska dekho, charge. Okay. Sorry, I think I went back. So this is the anterior peritoneum. After you go so sometimes it is easy to go for the anterior peritoneum and push the bladder down. But in case of placenta accreta, you may have difficulty, and sometimes if the placenta is encroaching the bladder, you may even have to do so. Here in this case there was some difficulty because this was a placenta accreta, or you may have to do a intentional cystotomy if the bladder is encroached by the placenta, and you may find that the Foley's catheter comes out in your during your operative procedure. But don't worry, if there is some bladder injury, it is repairable. Okay. See, go for the posterior peritoneum, dissect. So whatever you do in your gynec surgery, the similar steps are there. Only edema is there, and you have to keep a very clean field here. So posterior part has been dissected, bilateral uterine have been clamped. Now once you clamp the bilateral uterine, if it's a cesarean section, you may decide whether you want to do a supracervical or you want to remove the whole of the uterus. Okay, so that decision you have to take on table. Okay, go for the McEnroe's ligament. Open the vault, clamp, and remove. So you have seen here that quickly the hysterectomy has been performed, and you have done you may do a subtotal or you may do a total hysterectomy depending on what case it is. But even if you do a supracervical, that is a subtotal hysterectomy, it may suffice in cases where patient is bleeding heavily. But if your placenta is the main problem and the lower segment is bleeding, then you may have to do a total hysterectomy. In this case, of course, we had to do a internal iliac ligation also, and that the patient could be saved only after a internal iliac ligation. We can see the internal iliac here, which is being ligated, but I don't want to show the internal iliac ligation. I just want to stress that in cases where the skill is not there for internal iliac ligation, the time is not there, patient is in hypotension, you are not able to visualize anything, so and patient is, to save the life, you may have to go for an obstetric hysterectomy. And especially in cases of placenta accreta, you may directly have to go for a planned obstetric hysterectomy. So you need a team, of course, you need a good support, you need a backup from the blood bank and the anesthetist and the physician. Of course, your team has to be trained, but of course, हम कहते हैं कि जिगर भी चाहिए. Okay, so that courage comes from, and confidence comes from your skills which you have trained yourself. So that's why we say, of course, infrastructure, support of physician, anesthetist, blood transfusion facilities, all are required. Teamwork is required. Nobody can save a life alone. It is a teamwork. Of course, the skills of the surgeon also very important. Assistant needs to be trained. You need a team. Of course, we have a team, and that's why this is my team at Jawaharlal Nehru Medical College, and I'm proud of my team, my staff, who is always there. The department of obstetric gynae here is very helpful, and a lot of support from the anesthetist and blood transfusion facilities are very good. And helpful administrators also, I'm proud of them. So we are continuing in our mission for fighting for survivors. Every day we get some of the other patient who needs the skillful decisions, and that is what we are here for, to train ourselves to take this. Special thanks to all the people who have made this special presentation possible. Dr. Kiran Dhurve, who is my lecturer, Dr. Annam, again a senior resident, Smriti Khandelwal, Nidhi Makhija, and Harth Tilwa, who are our residents with me. So special thanks and credits for this presentation goes to my team. Let us pledge to make birthing safe. Thank you very much. And thank you, Vaidehi, for giving this opportunity to present my work. So now
Thank you, Dr. Surekha. My God, you have taken us to a roller coaster ride. Actually, really, your voice, Surekha,
thank you.
So articulate and precise.
It's
a really pleasure, and treasure means what I should say about you. You talk so nicely, you teach so nicely. I was thinking like I'm sitting in the class and you are giving it's really fantastic. The skills and drills. You acknowledge your virtual lab, your Varda department. So much of humility you have. And
no, it is never alone. Nobody can do anything alone. I always say that it is a teamwork. Thank you.
I'm appreciating you for that. What is drill? Systematic repetition of concepts. And the virtual lab that you have, the advanced mannequin, even Dr. Niranjan said Mumbai doesn't have it. So Varda Medical College is so lucky to have a teacher like you and to have the advanced mannequin to teach them the drills. Your Eclampsia drill, the Breech complicated, uncomplicated Breech, all maneuvers, symphysiotomy technique, the external cephalic version, shoulder dystocia helper, and lastly, the obstetric hysterectomy. It will not be absolute, no doubt about it, as long as the uterus is there and the birthing is happening. So in all, Surekha, I must congratulate you, and what a fantastic presentation. First time I have seen such type of drills after long. Means we have not seen these advanced mannequin because in our residential days it was not available. So it is really, it is means the students are so lucky to have such advanced techniques to learn from. It's really fantastic. Thank you, Vaidehi. Thank you, Surekha, for having me here. And I must acknowledge the Nagpur Obstetric Gynec Society. I have many friends there. Dear friend, my childhood friend, Dr. Ujjwala Deshmukh, Sushma Deshmukh, and Dr. Vaidehi, Dr. Surekha, and the list is unending. So thank you for having me here. And it was really a fantastic presentation. I'm so happy I'm here. Thank you. Over to you, Vaidehi.
Thank you.
Niranjan sir,
yeah. Thank you, Dr. Surekha. It was a wonderful presentation given by you. You have covered all the points, and your lecture has gone from 4:30, 4:45 to 1.5 hour lecture. A professor only can give a lecture of 1.5 hours. And I want to tell you one more thing. In the central part of India, in north, Nagpur. Nagpur is a place where you have the central most point of India, and that is where Dr. Vaidyahi Marathe is the central point.
Definitely. I can always acknowledge Nagpur people, and over the years, they have always encouraged me and always invited me, and I find that Nagpur is a second home for me. Vaidhi, especially my very dear friend, and I really acknowledge her team, Swati Sarda, and Rajasi, and so many. All the team, they are really wonderful. The kind of work they are doing. Definitely.
Thank you, Surekha. You are.
I want, with the permission of the president, that can I ask some few questions which are being. There are probably 100 praises for you, Dr. Surekha, not only for your attire and the presentation which you have, but for also.
He's a role model.
But also the technique which you have showed about how to go and do symphysiotomy, go ahead and how to deliver the shoulder dystocia, about the eclampsia drill, about the Piper's forceps, and the devascularization stepwise. And more than 500 members joined on your presentation to listen to you.
I was full show, Surekha.
Yes.
Thank you.
And in between there was a transmission glitch, but we could absolutely take over. It was just about 2 to 3 minutes. So there are doctors I can't take everyone's name, but many of them have appreciated you. Dr. Aarti Suryavanshi, Dr. Vandana Pandit, Dr. Mitra Saxena, Dr. Redmi, Dr. OnePlus, Dr. Namita Das, Dr. Yalanki Indira, Dr. Rani Chittor, Anita Rajoria. Yes, she is our Delhi AOGD member. Thank you, Vaidai and NOGS. Alka Agarwal. Then we have Dr. Mamta Shrikar Kumar, Afreen. Again, Sheetal Bhandari. And there are some comments also which we have come. So I can just go on and go on, but let's come to the point.
Before the question and answer, sir, we take a 2 minutes break and always make some announcements. Will you allow that, sir, please?
Yes, yes, please.
Because that will allow Surekha a break of 2-3 minutes.
Yes.
We'll just take 2 minutes break. Till then, Swati will make certain important announcements.
Thank you, madam.
Surekha, please have some water, and then we'll get back to you. We'll flood with all the questions that we have for you.
Madam, if Dr. Swati is not coming online.
She's there, sir.
Sir, I'm there. Actually, I was trying to put it on the slideshow. Yeah. Dear participants, this is there are 2 announcements. The slide which is, ma'am, I'm trying, it's not happening, slideshow. Screen share is, you can see the screen, ma'am?
Yeah.
Okay. Trying to put it on slideshow, but anyways, the slide which you are seeing is for these. There are 2 numbers from where you can avail the ICOG credit points. Our today's session, we are thankful to ICOG for granting 1 credit point for our today's session. You can call up these numbers and get the information on how you can avail the credit points. And the second. This is the second number for our, like Madam has already shared, that we conduct every week academic sessions on DGO GAN. And to know more about these sessions, you can just send your name and number to this NOGS official mobile number, so that we can keep you posted about our further DGO GAN sessions. And we are thankful to Sun Pharma for for sponsoring our today's academic session. Thank you very much.
Yes. So till the time Surekha comes, I will appeal again with the permission of Nagpur Society. And Madam, can I?
Yes, sir.
Yeah. So this is in Marathi. Saprem Namaskar. एखाद्या मनुष्याच्या संपूर्ण जीवनाला काही अस्तित्व मिळण्याची वेळ येताना त्यांनी इतरांना परिपूर्णपणे मार्गदर्शन असे माझे म्हणणे आहे. मी तुमचा डॉक्टर निरंजन चव्हाण, IAGच्या कारभारात आतापर्यंत एक समिती सदस्य म्हणून 6 वर्ष कार्यरत आहे. मी या विस्मयकारक IAGला प्रत्येक स्त्रीरोग तज्ञाकडे नेऊन त्यांना एंडोस्कोपी नवीन प्रशिक्षण आणि दृष्टिकोन देण्याचा प्रयत्न करणार आहे. हा माझा एकमेव उद्देश आहे की प्रत्येक स्त्रीरोग तज्ञाला याचा लाभ व्हावा. यासाठी तुमचा सहभाग अगदी महत्त्वाचे आहे. मी तुमचा उमेदवार डॉक्टर निरंजन नारायणराव चव्हाण आपला आशीर्वाद आणि आपले अमूल्य मत याची आशा करतो. आणि एक संधी IAG करिता. जय महाराष्ट्र. वोटिंग लाईन 1 ऑक्टोबर पासून सुरू होणार. आपण आपले मत द्या आणि चूज द राईट कॅन्डिडेट. नमस्कार.
Thank you, sir. Surekha, are you ready? Should we start the Q&A?
Yes, yes.
Should I start now?
Am I audible well?
Yeah, very much.
Okay.
So there are requests for repetition of certain procedures. Friends, I would like to inform you that we have recorded today's session and it will be uploaded on our website. Please scroll through the chat box and we have given a link to the website, our NOGS website, and this session will be uploaded in maybe 2 to 3 days max. So you can don't request for repetition of the procedures. You can go back and view that recording again, so that it will save time. Because Surekha has already spoken for more, I think 1.5 to 2 hours. So it will be a bit of injustice for her to go on repeating the same thing again. Then initial questions are all about repeating. Please explain from which side we should apply suprapubic pressure in shoulder dystocia. Surekha.
See, we have to apply. So basically we are talking of, flexing. You have to apply in the suprapubic region, and we advise that you make a fist, because you want to dislodge the anterior shoulder below the symphysis pubis. So you go downward and backward manner, and you are applying in the suprapubic region in such a way. You're seen in the video how the anterior shoulder gets dislodged. So you have to apply in a sort of a fist, in a downward and backward manner, and in a continuous and consistent manner. Don't give intermittent pressure. You give a pressure in a downward backward manner, and your aim is to dislodge the anterior shoulder below the symphysis pubis. And if the shoulder gets visible, and then you can hook the shoulder and remove it.
Right. In Akrita, at what gestation should we pose the patient for elective section?
Usually we are saying that till 34 weeks, first cutoff is actually the 34 weeks. Beyond 34 weeks, carrying a Akrita is not advisable. Around 34 weeks, you give your steroids and you post the patient for elective cesarean section.
Yeah. For eclampsia drill, it was an excellent presentation. There are lots of compliments for you, Dr. Surekha. You must, after the presentation, take some time and go through the chat box. It will make your day. Please add, she's just mentioning, it's a comment from Dr. Vandana Pandit, that please add SpO2 and Foley's catheterization after the loading.
The Foley's catheterization,
Yeah, I know. Yeah.
But it was probably not very well visible. But Foley's catheterization is very important. And in Dr. Annam's comment, she said you ensure the Foley's catheterization has to be there.
Yes.
Yes, we take that comment very constructively.
Yes, thank you.
And SpO2, of course.
Yes. And in ECV, can you suggest M mode fetal heart monitoring on ultrasound during the procedure? Will you recommend that?
In the external cephalic version,
ECV,
yes, we do recommend that we have to do an ultrasound well. Why? Because we want to know where the placenta is. If the placenta is a previa, then it is a contraindication for ECV. So you never do an ECV without an ultrasound. You do a proper antenatal ultrasound. You find out what is the estimated fetal weight, what's the amount of liquor, is there any uterine anomaly, is there any fetal anomaly. So that is, before you do a procedure, you should have a level 2 ultrasound with you. While you are doing the procedure also, you repeat an ultrasound to get an orientation of where the back is the head well flexed, is there a cord or something which you should, will there be some hindrance. So before that you can do a ultrasound, or even a good palpation of the abdomen also may suffice if you have already done a good ultrasound. So that's very important. And of course NST is also very important to find out if there is any inadvertent distress which you may not have picked up. So confirm that the baby is good, reassuring fetal heart is there, and then only go for a ECV. But it's a simple procedure, I can tell you, in an OPD procedure.
Right. In symphysiotomy, since only anterior ligament is incised, why is the urethra pushed to one side with fingers?
See, I understand what you're trying to say, but of course, protecting the urethra is the first key principle of symphysiotomy. You may not see inadvertently, if you go and cut the posterior ligament, you may injure the urethra. So the first principle is identify the urethra by a red rubber catheter or a plastic catheter, and then insert with your index finger, you put the urethra to one side, make it safe. So that is the principle, first principle always.
Yeah. Again, a few requests for re-describing the procedure. I'll again remind, please go back on our website. 2 to 3 days later, you will get the recording. Can we give loading IV dose of Maxel 4 grams in IV normal saline 100 ml over 20 to 30 minutes in eclampsia patient?
Yes. Yes, some of the practitioners are doing this also. Okay, so you may give either what I have shown in my video is what is Pritchard regime exactly described, and what I have shown, if you remember the video, is the provider actually sits on a low stool, so that what we advise is 10 to 15 minutes to give the IV bolus dose. So you have to actually sit nicely, catch hold of the wrist of the patient, put your one hand on the pulse and palpate the pulse, and then slowly give. If you're not sitting, you're standing, I can tell you within 2-3 minutes only you're going to give that IV bolus. So that's why we advise you nicely sit comfortably, watch the respiration, the pulse, and actually give it very slowly. But yes, you can put it into an infusion, very slow infusion over 20 to 30 minutes also, but we advise that it should be given very slowly with a emergency trolley ready. If you find some distress, respiratory depression also, you can stop either the infusion or your IV bolus and go for resuscitative measures. But I have been through so many years we have given IV Maxel, but I have not, only once we had encountered a respiratory depression, but it is possible that there may be a distress or a arrest, respiratory arrest, so your emergency trolley has to be handy.
Right. And for Maxel, for how long should we continue after delivery?
This is a very good question, and which we have missed in our drill. So let me explain to you. If it's an antenatal patient, like we have shown in our drill, so magnesium sulfate will be given for 24 hours after the delivery or after the convulsion, last convulsion, whichever is later. Like in this patient, she has convulsed, then we have decided for delivery. So after she delivers, then 24 hours after the delivery, till that time you continue 4 to 6 hourly, 5 gram intramuscularly in alternate buttons. Now, suppose your patient is postpartum already. You did a cesarean section in the postpartum period, she went into convulsions. So till how much time you give? So that is after the last convulsion, 24 hours duration. So that's why in your books it is written, if you remember this, I'm talking to the students directly, that 24 hours after the delivery or 24 hours from the last convulsion, whichever is later.
Later,
yes.
Not early. Yeah, correct. Yeah. Surika, there are loads and loads of compliments, but this I want to read out, but that person has not named himself or herself. He or she says, Dr. Surekha, I want to meet you. You are a very wonderful teacher.
Okay, thank you.
So this is a question from Dr. Navneeta. She said, what precautions to be taken during cesarean section to avoid adhesions? Sometimes it is very difficult to identify structures in the next section. So any tips that you can give?
In cesarean section, if she is a primea gravida, a simple technique which we call Misgav-Ladakh technique. If you go through the Misgav-Ladakh technique, then it's a very simple technique, has been described for cesarean section. Don't go here and there. Just you identify your entry should be clean entry. You do not cut too much in Misgav-Ladakh technique. You just stretch, okay, and allow the natural planes to open up themselves. That's the Misgav-Ladakh technique. And your incision has to be clean incision. Also, with the help of a finger only, you extend, and you do your suturing also in such a manner that too much of your decidual should not be exposed outside.
Correct.
Okay, so do not allow space for further hematoma to occur. Your alignment should be proper. Do not take too much thickness also, 1 centimeter from below and 1 centimeter from above. So your alignment also should be proper, and do not pull too much on your sutures also, because what happens if there is the blood supply is hampered, also healing is not there. And in Misgau-Ladakh technique, what happens, the peritonization also may or may not, you may do the visceral peritoneum, you may close or may not close. Then I do not advise exteriorization of the uterus. You know, exteriorizing or packing both the gutters, all these we do not advise. Simple cesarean section, do in a quick in, quick out technique, and do not touch too much a bowel or something, you know, and remove the baby and the suture in a very simple manner that reduces the adhesions for the next operation. Now, one of teachers, Professor Samal, she used to use flagyl. You know, after the cesarean section was done, she used to put 500 ml of flagyl in the peritoneal cavity, and she had an experience that reduces adhesions. But in the Misgau-Ladakh technique, no such recommendation is made that you should insert flagyl or something. Simple technique, and single layer closure, and that's why adhesions are very less.
What about peritoneal closure to avoid adhesions?
We do not do in a Misgau-Ladakh technique. The peritoneal closure is not advised. But if you want to do, use minimum amount of suture. You may give a purse string suture. So in a purse string suture, you use less amount of suture material, and that reduces the adhesions.
Okay. What are the second line drugs after the maximum dose of 220 milligrams of IV labetalol has been given?
Okay. So there are various drugs IV for IV lab. After IV labetalol, you can use nifedipine. Actually, the RCOG recommends nifedipine as the first line drug, where you give per oral only. You give nifedipine. You can give 20 milligram, but only thing is you avoid the sublingual nifedipine, and labetalol is the best. Now, just yesterday, a day before yesterday, we had a patient who had a postpartum eclampsia, and she had a 200 by 130 blood pressure even after giving magnesium sulfate. So in such cases, you can use IV nitroglycerin in an infusion through a micro drip. But let me tell you that nitroglycerin drip should be given with the help of an anesthetist or an intensivist who is a standby intensivist, and this nitroglycerin is given in a very small, starting with a small dose, and it should be given titrating dose and then with a close observation of the patient. So for us, in an hypertensive crisis, we recommend first line is IV labetalol. You may use nifedipine, and you also use this hydralazine. Okay, but that is not available. So what is available with us is labetalol, nifedipine, and if not, then you may also go for nitroglycerin. But nitroglycerin usually preferred in an ICU setup with an anesthetist and a physician who is there with you.
Right. Is there a chance of placenta accreta in a posterior low-lying placenta? Is there a possibility?
Posterior low-lying
placenta.
accreta.
Can there be an accreta in such cases?
See, I have seen accreta even in fundal. Okay, fundal placentas also. If there is some history of medical termination of pregnancy, or some DNC has been, some procedure has been carried out, and that placenta gets stuck to the myometrium, even in a fundal placenta, I have seen placenta accreta. So if it is a possibility or not, again a question of debate. Mostly it is seen wherever the incision is. Okay, it's a previous cesarean section, then that is where the placenta encroaches and erodes the myometrium. You have to do a proper ultrasound and see the myometrial and placental interface. If there was some procedure carried out, then it may be a possibility.
Right.
So if you done an MTP and there was a posterior perforation, it's a possibility.
Right. After symphysiotomy, should we suture the skin and do the strapping? What is to be done?
Yes, not the actually the symphysis pubis actually that joint, but the skin has to be sutured and strapped, to just approximate. And we also strap the knees of the patient so that there is no movement.
Oh, strapping both the knees together.
Together, yeah.
That is done for how long?
Just for that 24 hours period, and you catheterize the patient and allow her some rest, bladder rest also. And some people advise 24 to 48 hours of knee strapping, but not more than that.
Right. And would you suggest any dose of Maxulf in an eclampsia patient prior to shifting the patient to a higher center?
Yes, see, magnesium sulfate, the MAGPIE trial has been carried out, and very nicely the trial has mentioned that cases of eclampsia and severe preeclampsia should receive the full loading dose of magnesium sulfate before shifting to a higher center. That's why we are teaching this. So not only for obstetrician, this is also for medical officers. We have trained medical officer, non-specialist, to deal with eclampsia, and we advise that the full loading dose should be given. Now, even that's why we teach so well IV magnesium sulfate. But if you are not very well versed with, or you're not confident, and at least give the intramuscular dose. One thing you should remember before shifting any patient to any referral center, you should write down very clearly what you have given. So write down, if intramuscular dose, then please write down that and send to higher center, because the person who is in the higher center doesn't know what has been received and whether that IV dose has to be given. So I recommend that you should give the full loading dose and send with an accompanying person, maybe a nursing staff or whoever, but please give the full dose. If not, then at least give the intramuscular dose and send the patient.
Right. Two back-to-back questions for symphysiotomy. What is the anesthetic used, and what's the approximate thickness we need to cut through in symphysiotomy?
See, after the skin and subcutaneous tissue, you directly encounter the symphysis pubis. And I have not done myself, but I have seen a live video, and I have done a workshop actually in which the symphysiotomy has been done. The thickness will be depending on how much subcutaneous tissue is there. Okay, around 1 centimeter is 1 to 2 centimeter you will encounter the and if you within 1 centimeter you will reach the symphysis pubis.
Right. Do you think in shoulder dystocia, inserting tube for rotation is easy as compared to posterior arm delivery? What are the chances of plexus injury? Are there any studies of success and complications?
So there has been a study. See, if you noticed, this video has been uploaded on the reproductive. You may go on the website of Reproductive Health Library of WHO. Okay, and the shoulder dystocia video is very nicely given there, and they have given the study also where this procedure was performed. Okay, so they use a feeding tube to feed in between the axilla and then use it as a traction and rotate the baby. Of course, you need to be trained in all these procedures. You have to, you cannot just see, shoulder dystocia is really panic situation. I'm telling you. Okay, unless you train yourself, you are not able to achieve this maneuver. In my experience, my experience is that Macrobert's maneuver you should be doing very well, and maximum time shoulder dystocia is relieved only with the Macrobert's maneuver. And next very good maneuver is delivery of the posterior arm. So you go posteriorly, there is a good space there, you catch hold of the posterior arm and remove it. I do not have any experience of the feeding tube which has been used. I showed you because that has been done as a experimental or research setting, and I do not advise that this kind of procedure which is done in the research setting should be done by a single consultant. Person who is doing as a single consultant, private practitioner, should not go for this. But in a research setting, if you are well aware, then you can. There is a publication on it. You may go on the Reproductive Health Library of WHO, and they have there is a publication on it.
Right. And maximum time limit by which delivery should happen following eclampsia scissors?
Eclampsia after, there is no such time limit given. I can tell you in Sevagram, there was a research project going on, and we used to, in a research setting, again this is a research setting I am talking about, not a recommendation as such, but we have carried the patient over weeks also, you know, to reach the first cutoff of 34 weeks. Suppose a patient coming you with 32 weeks and she is very well settled. So we give magnesium sulfate, observe the patient, and we decided that we can carry that patient for 2 more weeks and she will deliver after that. But this is only as a research setting. This is called as intercurrent eclampsia, where we carry the patient for maybe a few days or a week and then we deliver. But it is given in the books that you should take an immediate decision for termination, and that is what we recommend. So whatever you do for your other patients, like you do an induction of labor, you know, either with misoprostol or with oxytocin, and then you watch the progress of labor, and once the 4 centimeter dilatation has been reached, then 1 centimeter per hour dilatation, that is next 6 hours she has to deliver, but depends on, you know, the Bishop's score. So as you have asked me the question, time limit in research setting, it may be different. Otherwise the recommendation is that you go for immediate termination.
And how to give calcium gluconate as an antidote?
Yes, it's an antidote.
How to give?
So 10 ml, okay, of 10% solution of calcium gluconate, you have to give very, very slowly. 1 ampoule of calcium gluconate is containing 10 ml, okay. So you give very slowly. Again, just because of calcium gluconate also, patient may go into cardiac arrest. So give it very slowly, as you have given your magnesium sulfate over 10 minutes. So we say 10 ml, 10%, 10 minutes.
Right, right. And what is the role of phenytoin in eclampsia and its dose?
Okay, so phenytoin again, you know, used to be used early, previously, and even now if you go into medicine ICU, once the patient convulses, they give 100 milligram of IV infusion of phenytoin. Okay, but obstetrician, as an obstetrician, eclampsia patient, we give magnesium sulfate. Role of phenytoin may be if the patient convulses later on, and many times I have seen that if the patient is in medicine ICU, they first start phenytoin. So phenytoin is maybe used if there is some other cause, maybe epileptic seizures, patient is in septicemia, she is convulsing because that. For eclampsia, we don't recommend phenytoin at all as the first line. The first line is magnesium sulfate only. And if she doesn't respond, then newer drugs like levetiracetam is available, which is called as Livipril. And only 2 days back, one of my patient who had 3rd or 4th convulsion after giving magnesium sulfate, and anesthetist advised IV levetiracetam. The dose of levetiracetam is 500 to 1500 milligram in divided doses. So we started for that patient 500 milligram IV infusion, and twice a day we gave that patient. So phenytoin sodium, again in a medical ICU setup, they prefer.
Right.
But for eclampsia, we prefer magnesium sulfate.
Yeah. What's your opinion about allowing Decidia to be included in the suture line?
Okay, now there are various schools of thought here. Initially, we used to say that you should exclude the decidua. Okay, and we used to always teach our students how to exclude the decidua and you know, take our sutures. But over the years, various studies and publications have come up that even if you allow the decidua to be taken in the suture, there will not be that amount of problem. But what I advise is that decidua should should not be peeping or popping out of your sutures once you have sutured. Sometimes the sutures taken are so bad that decidua is seen popping out of the sutures, your suture line, and then the suture are unhealthy and the scar is very bad. So if you take your suture also, you should assure that the approximation is very good.
Right. After vaginal delivery in a retained placenta, how to diagnose placenta accreta before attempting an MRP? Any tips?
Now, this is a very tricky question, I'm telling you. Unless a good ultrasound has been done, and you have a ultrasonologist telling you, okay, see what we can do in a MRP. What we used to do, at that time, what if we have attempted an MRP? You have attempted an MRP and you are not able to find a good plane. So how do we describe an MRP? You catch hold of the cord. It should lie parallel and horizontal to the ground. Okay, so you have to pull on the cord, follow the cord very well, go to the edge of the placenta inside and try to form a plane in between the placenta and the wall of the uterus. Now suppose if this is the placenta, you go in this manner. Sweep your fingers in this way and try to get a plane. Now, if you don't encounter a good plane, sometimes you may yourself, your observation will tell you you're not finding a good plane. Once it had happened with me and the placenta was adhered, what I did in that case, I left the placenta behind. Okay, she was not bleeding at all. So if a MRP, if a retained placenta patient not bleeding at all, okay, that may be one of the sign that this is a adherent placenta, and you may better leave the placenta behind and give methotrexate instead of trying to insinuate your hand and remove half the placenta and keep half the placenta behind and lead into torrential hemorrhage. One case I had left the placenta behind, just cord was removed and the placenta was kept inside, methotrexate got given and autolysis of the placenta was allowed. So that two things I have told. If there is no bleeding and if your attempt to insinuate your hand is unsuccessful, you are a trained person, but if it is unsuccessful, leave the placenta behind.
Okay. Now this is one question not entirely related to our topic today. Dr. Kelgaonkar is asking you if lower uterine segment thickness given by a radiologist in a patient of previous LSCS at 19 weeks. Gestation is just 4 mm. How should he manage this patient further?
Don't do anything. See, at 19 weeks of gestation, see, we know that the lower uterine segment starts forming at a later gestational age. So what is the what is it, a thickness? What is it? If the lower uterine
lower segment thickness in ultrasound is mentioned. I don't know why the radiologist has measured the lower uterine thickness first of all, but at 19 weeks it was measured and it was 4 millimeters. So how should he manage that case?
Oh, they are talking of the lower uterine segment thickness. Of 4
not
mm.
the scar. I think he should mention. I think he wants to mention the scar. I believe.
You're talking of the scar
if you
thickness.
can mention that, you can rephrase your question maybe once again.
So, okay, thickness of the lower uterine segment, not the scar, right?
Should be the scar.
I think you need to follow up this patient. I'll advise that you follow up this patient. Do a good ultrasound to find out if there is the placental and the myometrial interface. How is the interface? And is there any encroachment there? You need to follow up this patient very well. And if you find that there is sign of encroachment, then you need to follow up this patient and manage the patient as a accreta.
Yeah, Dr. Dekera, I have unmuted you. If you just want to quickly ask what you really want to know.
Yes, ma'am. Yes, ma'am. Hello?
Yeah, go ahead. We can hear you.
Please go ahead.
Yes, ma'am. Actually, the radiologist has given that lower uterine segment, I think scar.
Must be scar.
4 mm. Yeah, 4 mm.
Okay.
So, in this
Thin
early...
scar.
Yeah.
You need to follow up this patient very well, madam. and you need to take a second opinion also from a radiologist to find
Another
out how
radiologist.
the placental, how the placental interface and myometrial interface is, if there is encroachment. So at 19 weeks, if you find, I had a patient who had a complete encroachment at
Placenta
24
is
to
at upper
26 weeks.
segment. Placenta is at upper segment.
Okay, so thin scar. Okay,
Thin
so
scar.
you need to manage the patient as having a possibility of scar dehiscence. She should be
Okay.
on. She should be under your observation. Okay,
Okay.
and so that what is the size of the baby, the estimated fetal weight, there should not be a too huge increase in baby or a polyhydramnios. So all these signs, alert, you should be alert that this patient should not have a scar dehiscence, early scar dehiscence.
Yeah,
And you
there may be
keep
chance
on,
of early.
you can
Yeah.
keep on performing. Sometimes 4 mm is not that, you need to follow up.
Okay.
Also, Dr. Zakira, ultrasound will never give you the idea of integrity of the scar. It will just give you the thickness. But that in no way will tell you how strong is the scar. Please go back on our website and see our session on by Dr. Suresh sir. He has very nicely explained the role of ultrasound in lower segment scar thickness. So I think that will solve many of your doubts. Okay. All right, coming to the next section. If previous LSCS, lower uterine segment is very thinned out while suturing and sutures are getting cut through, how should we suture and increase the strength of the sutured segment?
Yeah, this happens many a times. It's a previous cesarean section, a thinned out lower uterine segment, and if you have not adequately pushed the bladder down, then you're not able to get too much nice tissue, lower segment tissue. What I recommend is, while pulling, what happens, how it cuts through, how you pull on the thread.
Correct.
So you don't pull on the side where it will give way. Like नीचे से अगर ले रहे हैं ऊपर, तो pull on the other side, so you don't have too much stress, and do not, you don't want to, you just want to approximate.
True.
So be very gentle with the tissue, take adequate amount of tissue, then see that the bladder is, you may do sharp dissection so that the bladder is adequately down, and you take a thick tissue, and the pulling of the thread has to be in such a way that you do not give too much traction on the lower segment, but your pressure is on the upper segment. You find that the difference in size between the lower segment and the upper segment is too much. Lower segment is too thin, upper segment is too thick. So you need to pull on the side of the upper segment while giving traction on the suture.
Right, right. What is your opinion in a patient of previous repeat section? Do you give incision through the previous scar or you give a little above?
No, please repeat the question.
Your uterine incision in a patient of repeat LSCS, whether you go through the previous scar or you give it above the previous scar?
Little above the previous cesarean section, that is advisable. Okay, don't go through the previous scar. And again, when we do that, we should assure that the bladder is adequately down. If not, sometimes it happens that the bladder is so adherent that it doesn't get pushed down. So little bit above the is always advisable, because it retracts. After removing the baby, it retracts.
Okay. Single layer or double layer suturing?
Again, it is a two schools of thoughts, and various studies are there. Before, when I was a resident, we used to always do a double layer, and we used to be taught how to bury the first layer. Then with the Misgau-Ladakh technique, what happened, that the single layer technique came into vogue, and the research, and for many years we used to do single layer. Then again certain research came that no, we should again go for double layer. What I advocate is, we have been doing single layer and we have not seen many problems in our practice, so we advocate single layer. But sometimes it happens that if you find that the hemostasis is not being achieved well, then you may go for a double layer. But routinely we follow single layer.
Okay. Again, one more question about phenytoin. After phenytoin was given in a medical ICU, when can we give Maxelf in a patient of eclampsia?
See, even if phenytoin has been given, you should go for a full dose of magnesium sulfate.
Right. Clear.
That is advised.
Yeah. And in a patient of retained placenta where you left the placenta behind, what is the dose of methotrexate and the route of administration?
50 milligram, as we advise for other, that is the dose, same dose.
Okay. And can you just tell us how you monitor such patients and what happens after you give methotrexate?
See, what happens, you have to monitor the patient not only with your beta HCG levels, but also with an ultrasound. With good ultrasound, you have to monitor this patient and see whether the autolysis has been achieved. And you have to also tell the patient that she may pass some pieces of placenta, not to get afraid. There may be a secondary hemorrhage. If there is a secondary hemorrhage, she has to come to us. There also you have to monitor this patient for septicemia, some sort of sepsis later on, because the placenta is left behind. So there are quite a few studies on this also, how some placentas have been left behind, and they had to, in one of our patients, we had to follow up the patient for almost a 8 months period before the placenta got absorbed. So if you are taking a decision to leave the placenta behind, you have to be ready for a chronic follow-up of the patient. Your patient should be amenable to follow-up. If she's a rural patient and she doesn't come back to you, then these are the patients you just cannot leave them like that.
Right. I think we are coming to the end of the Q&As, because there are lots of questions which are asking for repetition of symphysiotomy, repetition of certain drills. Let me again tell all of you that we have recorded this session. Not only this, we have recorded all our previous DigiOrgan sessions and they are available on our website. Dr. Swati Sarda has posted the link to our website in the chat box. The last message was at 6:17 by Dr. Swati Sarda. Please scroll through the chat box. You will get the link of our website. At 6:17 is the last message. 6 o'clock, 6:17
There is a comment from Dr. Vijay Lakshmi about methotrexate, which I wanted to read. Yeah. Yes, madam, I agree with you that there are a lot of second, thoughts about methotrexate, and that's why in placenta acrita, people do not want to leave the placenta behind, and nowadays there has been the recommendation for doing a plant cesarean section and plant hysterectomy for this patient with a vertical incision in the upper segment, but there has various studies have also given methotrexate also, and they had good results. Those publications are also available for you to go through, ma'am. But I agree about methotrexate. There has to be a very chronic follow-up of this patient, and sometimes patient may come with secondary hemorrhage, and then again she lands in obstetric hysterectomy. So you have to be, the supervision has to be very good in these patients.
Very good, yeah. One more question, Dr. Surekha. Ma'am, why do some patients have prolonged bleeding PV post cesarean section? How to treat it if they are not responding to tranexamic acid?
So we need to remember the 4 T's, no? So you are talking about tone, you are talking about trauma, and then lastly you are talking about tissue, and you are talking about your tissue. So if some part of tissue may be left behind, so you have to rule out 4 T's in these cases who are having prolonged bleeding, and if tissue is not there behind, and if there is no secondary hemorrhage because of sepsis, so you have given your IV antibiotics, you have ruled out the tissue is not left behind, then if the patient is still having a prolonged bleeding, then you may also think about gestational trophoblastic tumor, if there is a possibility of gestational trophoblastic tumor. So you go, in a sort of a structured manner in this patient. So only tranexamic acid, if you are given, patient is not responding, start a higher antibiotic, rule out if there is any tissue left behind. All this also has been ruled about. Then your patient is bleeding. Rule out any gestational trophoblastic neoplasm.
Yeah. Uh, Again, just one last question. If we find placenta accreta after vaginal delivery, can we take up this patient now for obstetric hysterectomy to avoid risk of
Yes.
secondary PPH and sepsis?
If your patient is bleeding, she is having placenta accreta after vaginal delivery and she is bleeding heavily. Okay, so you may have to take the decision for going for operative intervention in this case.
Yeah, but to avoid secondary PPH, she's saying. So maybe the patient is not bleeding. Just to avoid sepsis and secondary hemorrhage, should such patient be taken for obstetric hysterectomy?
If the patient is not bleeding, please don't touch the patient. You may leave the placenta behind and give methotrexate. When do we take a decision for hysterectomy? If there is torrential bleeding, and in that case you are not able to preserve the uterus. Okay, if she is having a circulatory collapse, if she is having a torrential bleeding which is not controlled by your medical methods, that is when we take the decision for obstetric hysterectomy. If your
Okay.
patient is not bleeding, if her vitals are maintained and she is not having any problem, why do you want to intervene?
Correct.
Okay.
Correct. Dr. Sureka, the questions are keeping on popping up in between. So I'll now really take the last question. Even if someone asks me again, not going to ask it. This is a private question to me. I'm putting it up for you. In placenta accreta after cesarean section, a gauze was kept in the uterus and uterus was sutured. But accidentally suture was included in the pack. Now, how should I manage this patient post-operatively?
Okay, so the gauze is left behind,
Yeah.
right? And it's in the uterus.
Looks like what he's asking me. So
okay,
so maybe he wanted to remove it vaginally, and now but the suture has passed through the pack.
So if you allow some time to go, the suture will loosen up. Okay, and if you have seen and see, so how that person must have realized by doing an ultrasound maybe. So ultrasound is showing some tissue which is left behind or some material which is left behind in the cavity. If you do it immediately after your surgery, there is a chance that patient may start bleeding at the time. And of course, if the suture has come, then it is not going to come out also. So you allow some time, maybe it will loosen up on its own, and after that you may go for removal, and if needed you may go for a hysteroscopic removal also.
Right. So finally, I think we have to end, because if I don't end, another question will pop up. And I can imagine you must be really tired. You've been going on for the past 3 hours.
No, I'm
and
not
it's no mean task, really.
Last time you remember, Vaidhi, we went till 8 p.m.
8
Do you remember?
o'clock. Yeah, last time your session went on till 8 o'clock. I can imagine.
Yeah.
But this has been a long session, lots of videos, live drills, and you have taken such a lot of efforts for us. I'm so thankful to you. This has been one big marathon session, an extraordinary session, as always, Dr. Sureka. We don't expect anything lesser than from you, So thank you once again, making it again simpler to all of you, those of you who have been asking me again and again about the website link. Dr. K. Sharda has posted the website link last in the chat box. So thank you, Dr. Sharda, for making this easier for me. She has posted at 6:59. So please take the link from there. Over to you, Chairperson, ma'am and sir, for your last comments before you wind up.
Thank you so much, Dr. Vaiddevi. You have already told and complimented Dr. Sureka. She's an encyclopedia of labor drills.
Absolutely.
And a lot of efforts. And I can see even now there are more than 200 members who have logged in. There are many questions which have come, but especially the mannequin drills and the efforts which has been taken by the Nagpur Society. And I would like to compliment Dr. Sarda. She is a perfect secretary. Last year I was a secretary of Mumbai Obstetric Gynec Society and Jaideep Tank was the president. So he was the secretary in Foxy's office and I was the secretary in Emoji's office. So I can imagine and I understand what are the responsibilities of a secretary. And Dr. Vaiddehi, you are so fortunate to have an efficient secretary, because I've been seeing from 4:30, it's nearing now 7 for 2.5 hours. She has been taking calls and she is replying to all the chat and assigning all the questions and wonderfully being executed by Nagpur Society. So it is one more hats off to you. And I want to add one more thing, madam. I think in whole India, Nagpur Society has done the maximum number of webinars.
I agree to that.
Yes, yes, yes.
I sometimes feel I may be blamed for that because it really started with a bang and now everybody has this webinaritis pandemic, whether we were responsible for doing that and initiating that thing. But thank you so much, sir. All your words mean a lot to us. Thank you.
Vaidehi, because you have been appreciated because you started with the basics. That is what people needed. The basics in ultrasound, basics in operative, basics in endoscopy, everything, even sonography also. So it was much more appreciated only because of foundation, the basic things made more clear with your webinars. And Sir Nagpur Surekha Taide, what should I say about you? Very nice. He's a really nice and
I have to thank Vaidehi because I have been trying to, record this video for long, but because we had decided, okay, we'll do it for Vaidehi's webinar.
And Vaidehi, the beautiful doll and the leader, the questionable queen of Nagpur. Thank you so much for having me here, and it was pleasure watching it all.
Our honor, ma'am, to have you with us today to chair this very important session. Thank you so much, ma'am. Thank you so much, Dr. Niranjan, for
Madam, if you can allow me just half a minute, I can't stop talking. We require leaders like you from Central India and Dr. Surekha Taide to please come up and take that effort to be a part of the organization. See, Foxy is 38,000 members, and I'm sure it is going to grow in leaps and bounds. There are many private practitioners and professors who are contributing in this COVID era, but there is something like also, self-responsibility towards the organization. And I see the leaders which are groomed up and which are coming up, and I need those helping hands. So Dr. Varsha Baste, you also will have to lead these efforts, and it's not only ending as a chairperson.
Yes, ma'am, you must. Politely.
Go ahead also with further positions, because that is what is a dynamism which you people play. So I would advise, or I would suggest from the bottom of my heart, Dr. Varsha Baste to come up forward, and also young dynamic Vaidehi Marathe madam, the secretary, and Surekha Taide to take that opportunity in the future years to come. And I will be besides you. I promise you that I'll be there at the helm of affairs in Foxy, and we will make it a better organization and very techno savvy, and we are going to take efforts and help from you. Thank you so much.
Thank you, Dr. Niranjan.
Thank you. It was a nice webinar. Really fully enjoyed. Academic feast and mast. Surekha bhai, mast ekdam. Good. Thank you so much.
Real feast, indeed, real feast. And ma'am has to attend another webinar, and in spite of that, such a hectic schedule, she managed to squeeze in and attend and be our chairperson today. Thank you, ma'am, once again.
Thank you so much.
In the chat box, again, in the chat box, Dr. Sharda has again posted the link to our website because you all are asking me again and again. So please check the scroll the chat box. Near the end of the chat box, you will get the link to our website. I think it's time to wind up the session. Before we do that,
thank you very much.
I'm inviting our Joint Secretary, Dr. Rashmi Vaisare, to propose the formal vote of thanks. Over to you, Rashmi.
Thank you, madam. Good evening, everyone. First of all, I'd like to thank the orator, Dr. Surekha Taide, madam, for this wonderful session, for the non-stop 2 hours. Thank you very much, madam. I'd like to thank chairpersons, Dr. Varsha Baste and Dr. Niranjan Chauhan, sir, for the smooth conduction of this session. I thank you all the participants as well. I like to thank a special thank to Dr. Swati Sarda for the smooth conduction of this DGOGAN. Thank you all. Thank you very much.
Also,
thank you. Bye. Love you all. Thank you
so much.
Thank you.
Thank you so much. Bye. Time to log out. Surekha, you really deserve one big break today. Now go and rest for some time.
No problem.
You've been talking non-stop for the past 3 hours. Now
actually, I'm not tired. Really.
Your masseters need some rest.
Oh,
Surekha, log into VBF group now.
Thank you. Yes, definitely.
Yeah. The next chat there, not here now.
Thank you.
Bye, everyone.
Bye. Good night.
Thank you, Dr. Niranjan and Dr. Varsha. Bye. Bye.
Bye bye. Bye bye. Thank you so much, everyone.